Thank you. So the other topic which I'll be talking today is predicting preoperative biomarkers for exaggeration of retinal pathologies post-cataract surgery. I know it's a very small title. So I'm sure each one of us have had days where we have done a perfect cataract surgery, but post-surgery you end up with some retinal pathology, either macular edema or so, or sometimes you have scenarios where you have retinal pathology, and then after the surgery it has progressed, and you feel really bad, and patient finally blames you. So to solve this question, we thought, okay, can we actually predict before surgery itself which patients can show worsening of retinal pathologies post-cataract surgery? So we did a prospective interventional study where we looked at 226 eyes. These were the inclusion and exclusion criteria. And we did a detailed examination from slit lamp to fundus photo and OCT macula at every visits. The aqueous was collected in all patients, and also the follow-up was done at 1 month, 3 months, 6 months, and 12 months. And we divided the groups between the two. First was based on the systemic illness, where we look at patients who had only diabetes, the second one only hypertension. The third one was both hypertension and diabetes. And the second group, depending on the presence or absence of retinal pathology. So as you can see the results, there was a significant increase in or higher levels of VEGF and MCP1 in groups in patients who had both hypertension and diabetes as compared to the hypertension group. And when we look at retinal pathologies, the VEGF and other inflammatory markers were significantly higher in patients who required post-surgery retinal treatments. So now we know that definitely there is a chance that once you do the surgery, that the already existing retinal pathology can increase in the future. Then there are certain biomarkers which you can pick up to see what who are those patients. So in fact, we are correlating these the biomarkers with the tears also, so that we can do a more non-invasive test before the surgery. That way, it's much easier for every doctor to do so. So basically what results we saw is we had the patients with diabetes and hypertension had significantly higher VEGF and MCP1 as compared to the hypertension group, and also the higher levels of VEGF and inflammatory markers were observed in patients requiring treatment post-surgery because of the retinal issues. So this is our concept. Basically, first we identify, second is we isolate, third is we do a customized treatment for that patient, not just the patient, the eye. So we have devised a kit, a diagnostic kit, which is a low-cost diagnostic kit, which any a solo practitioner in his clinic can have it next to him. And what do we do with this? How does the flow look like? First, we need to collect the tears from the patient and then put a buffer into it. And then once you have done that, you can put this into the cartridge and then the cartridge into the diagnostic kit. So once you have done this, within 90 minutes, you'll have the results in your hand. So what do we do with the results? So if you see any kind of high levels of VEGF or inflammatory markers, preoperative itself, you can make sure the patient there is strict control of systemic illness, no matter what it is. And also maybe depending on the situation, you have to maybe you can inject intravenous injections or so before the surgery itself. Then you go ahead with the surgery, and then again you need to closely follow up these patients so that the earliest sign of any changes, you can pick it up quickly, treat it so that the outcomes are much better. And obviously look for any inflammatory sequence in the diabetes and so on and so forth. So basically we are come to a new era where we are able to identify the biomarkers and create a very customized treatment for patients. That way, we're not doing these blanket treatments where we just do everything and then finally we are nowhere. So I'd like to conclude by saying the same, where the assessment of biomarkers in aqueous and tears can help in early diagnosis of retinal pathologies, resulting in better surgical outcomes of patients undergoing cataract surgery. Thank you for your time.
Dr. Narayan, what are the correlation you're making with the disease aspects? There are so many retinal pathologies.
Exactly, sir. So what we are looking here in this study is, doesn't matter what condition it is, sir. From diabetes to even sometimes, a completely normal retina, you end up with the macular edema. So we have taken all those biomarkers. Now we are in the processing to correlate with the tears. So, I mean, once that is done, it's much easier to answer to the patient also, because you know what's going to happen and you tell the patient, see, look, this is going to happen for you. So we need to do this, but still you're at risk. So if you say this, you know, the patients who develop complications post-surgery, they're more accepting and more understanding also.
So what's been your understanding thus far? You categorize the patients into 3 groups: diabetes alone, hypertension standalone, and both of them combined. So where do you, up till now, the observations, what do they suggest? Where do the markers?
See, the whole purpose of doing groups is to see the uniqueness of each disease, or to differentiate the biomarkers, which biomarker belongs to which group, or having certain these kind of scenarios of biomarkers, you will end up with this particular problem. So to identify that, we have to do these subgroups into, you know, be it retinal pathology, no retinal pathology, or diabetes, hypertension, and so on and so forth, so that, you know, identifying the biomarkers is much easier in the lab.
No, what I was asking was, say you have a patient who has a diabetes,
Yeah.
and vis-a-vis a patient who has hypertension,
Yes.
and you're going to operate
Yes,
on
yes.
that particular patient. So what has your observation led to? Do you have to be more careful with diabetes standalone, or diabetes hypertension combined, or hypertension standalone? What's your
Right.
observation led to?
As of now, the combination of the two are more higher risk of complications.
So if you would have had a patient who's got both diabetes and hypertension and cataract, and you've operated,
Right.
you probably would have called that patient back for a follow-up if
Yes.
the diseases are 5 years or more,
Definitely.
any which way in every 6 months. So has that changed now
Exactly.
after you've seen?
So it's not like every patient of diabetes and hypertension is going to end up like this. See, we can be, let's say, if we, okay, now if you know the biomarker that it is 100% chance that post-surgery you're going to develop with macular edema or the worsening of this, you'll be more aggressive in preoperative treatment itself. Forget about post-operative, because pre-operative they won't listen to certain injections when it's not indicated. But if you know these biomarkers, okay, you will end up with the edema or something like that. Pre-operative injection into the vitreous, would help the patient in a big way.
So you're doing that?
No, not as of now.
Not as
Not
of
as of
now.
now.
So
Because we
you're still
want
waiting
to.
for-
Yes, because we need to have larger data and publish it and then go ahead, because we can't do it.
Fine. Thank you.
Thank you.